All right, welcome back from our break. We will now move to our next panel, which is Immunization in Focus, Vaccinating Pregnant People. The science is clear. Maternal vaccination helps support both healthier pregnancies and healthier babies. The CDC recommends that pregnant people get several vaccines during pregnancy, and more vaccines are in development to help improve the lives of pregnant people and their babies. In this panel, the presenters will look toward new vaccines specifically being developed for pregnant people, as well as ways to improve vaccination rates in these patients. Our speakers for this panel include Dr. Geeta Swamy from Duke University, who's also one of our NVAC members, Dr. Flor Munoz-Rivas from Baylor College of Medicine, Dr. Courtney Olson-Chin from the University of Rochester, and Dr. Kevin Ault from Western Michigan University. Dr. Swamy, we will have your slides up. I see your face. You have the floor.
Good afternoon, Bob. Thank you. So I actually am going to just speak without any slides because I think there's a lot of really great information that's going to be coming from the rest of the panelists. And so what I thought I would do is maybe just set the stage. Bob gave a really excellent introduction on why immunization of pregnant people is an important topic and of the significantly important public health intervention. But I like to think a little bit about why we should be talking about immunizing a pregnant person. There's a difference between immunizing the pregnant person for the protection that offers to that individual versus the protection that could be offered to their developing fetus and future neonate. There are immunologic changes that occur during the course of pregnancy. We know that there are certain conditions, predominantly viral infections, that seem to have a higher, not necessarily higher susceptibility for infection, but more related to increased morbidity and mortality related to the infectious disease. And that could be due to changes in the inflammatory immune response during pregnancy, which we know is obligatory to avoid any maternal fetal rejection processes. But there's also a shift in how the pregnant person's body or physiology works. And so we know there are changes in particular in their respiratory or pulmonary system that probably are also due to some of that morbidity and mortality we see. In addition, though, pregnant people are people who happen to be pregnant. So if we can do things to protect that individual against infections that could be even lifelong protection or significant duration of protection against those infectious diseases, we should be thinking about that and not simply excluding a person from potentially beneficial therapies based solely on the fact the person is pregnant. And lastly, I'll say that pregnant people are in regular care and are accessing health care during the course of their prenatal care. So this is an excellent opportunity to be also delivering other aspects of primary care, such as vaccination to prevent infectious diseases. But when we immunize a pregnant person, we also are potentially immunizing the fetus. We know that infants, particularly in the early neonatal and early part of infancy, have a maybe, let's say, diminished or inadequate response to immunizations, such that it takes multiple doses, right, to build up the immunity, as we see in the infant vaccination series. And so by vaccinating the pregnant person, we actually can offer often short-term protection during the first few months of life because we leverage the transplacental passage or transfer of antibodies. That's actually a natural process. We know that antibodies cross the placenta to protect the infant, whether it's those antibodies are coming from vaccines or not. We see that in lots of studies looking at finding antibodies to specific pathogens that have nothing to do with vaccines. So we really talk about the ability to be able to vaccinate and protect both the mother and potentially the fetus and a neonate. But I will say that while it's a really exciting time now to be talking about vaccinating pregnant people, it is important to remember, again, as Bob said, that the data is clear that vaccination during pregnancy, using the right vaccines and specific ones that are of interest, is safe and effective. We actually know this historically, looking back to the days of the first smallpox vaccine when it was used to protect mothers and infants. We know this from the worldwide efforts to eliminate neonatal tetanus, and that giving tetanus and diphtheria TD vaccines during pregnancy has made a dramatic impact on preventing neonatal tetanus. And we also have seen this in and out repeatedly in the ability for influenza vaccine to prevent significant morbidity and mortality during seasonal influenza prevention, but also particularly in pandemics, dating back to earlier pandemics and certainly in the H1N1 pandemic as well. But why, again, are we talking about it now? Why is it of even more importance to discuss this? Well, from a really exciting past couple of years, we now actually went from prior to the COVID pandemic to having 2 vaccines recommended during pregnancy. Flu vaccine, which really the primary purpose is to prevent maternal influenza, and then Tdap vaccine to primary purpose to prevent pertussis in early infancy. So those 2 vaccines going to now where we actually have 4 vaccines recommended during pregnancy, with one of those being FDA licensed for use in pregnancy. You'll hear more about those through the talks coming up next, but now having influenza, Tdap, COVID-19, and RSV vaccine, which is a really exciting thing to have that in our armamentarium to prevent infection in mothers and infants. But there are still significant gaps. We know that we have not done a great job in thinking about this from the standpoint of emerging infections. For example, when there have been Ebola outbreaks, initially vaccines were withheld from pregnant people. Now that's a problem for many reasons, but given the fact that the mortality related to pregnant people and their fetuses related to Ebola is significant, to withhold a vaccine that potentially has benefit to them is problematic. We also watched the Zika pandemic or endemic go through without really having significant vaccine development or intervention. So there's still lots to do. Thankfully, there is a lot of work ongoing now, particularly looking at other infections such as Group B strep in early and late onset disease in the infant, looking at vaccines to prevent congenital CMV, and others that are in the pipeline. So you'll also hear from the other speakers about vaccine coverage. Many of the talks that we've heard today and even yesterday have talked about the, unfortunately, inadequate coverage of vaccines or poor uptake of vaccines in our country, particularly in adults. Most pregnant people are adults. We still do have adolescent pregnancy, but thankfully the number of adolescent pregnancies in the United States has been on the decline, which is a good thing because we know that the outcomes for adolescents in pregnancy can be rather difficult. But if you look at the coverage, you heard in one of the talks earlier about Tdap vaccination coverage or uptake in pregnancy, which still hovers right around 48 to 50%. But if you compare that to vaccine uptake in adults, it's actually not that far off. So I think, again, it's important to remember that pregnant people are people who are pregnant. So it's not that we should be looking at them to carry the burden any differently or any more significantly than other people. So we still need to think about all the ethical issues and the delivery issues, the supply issues, the access issues for pregnant people, just like we have heard about the discussions here for vaccines in adults. So I'm going to stop there and hand off to our next speaker, but I'm happy to join the conversation and the discussion as well.
Thank you very much, Gita. Our next presenter is Dr. Flora Munoz from the Baylor College of Medicine. Dr. Munoz, your slides are up. I see you. You have the floor.
Thank you so much, Dr. Hopkins. You can hear me okay? Yes?
Yes, you're loud.
Perfect. Perfect. Thank you. So I will discuss a little bit the issues of challenges and what strategies could be useful to continue to vaccinate pregnant people. The next slide is just to disclose some of my activities related to research and related to a number of committees that I participate in, mostly related to maternal immunization. Next slide, please. So, as a pediatrician, I know that we have talked about immunization in general as a continuum through life, and we don't give vaccines only to children anymore, but also to adults. On the early part of life, infants do also have a continuum of care that starts with the mother, and it starts with antenatal care all the way through delivery. And those very, very important first few months of life that the infant has, where there is a special susceptibility to infections. And this is due to the lack of active early immune responses to infant from to different pathogens in infants until their immune system is built up with their own immunizations. And during this time, it is really, really relevant that babies are protected through maternal antibodies that are passed through the placenta. And maternal immunization, as you can see here, is an opportunity to provide a boost or an increased level of antibody that will then provide this protection to the babies in the first few months of life. Next slide, please. We have heard how there are vaccines that are specifically recommended to be given during pregnancy, and those are listed in the very right side of the panel. We've heard from Dr. Swami the fact that we give influenza, pertussis, tetanus vaccines, and more recently SARS-CoV-2 during pregnancy. These mostly based on a risk-benefit assessment, and the only vaccine that is licensed specifically for administration to pregnant women with the goal of protecting the infant is the newly approved RSV vaccine in 2023. These are recommendations that are consistent throughout the world from the World Health Organization, but also in the US by the US CDC and ACOG. And as you can see, I have listed there that those are not the only ones. Actually, we do have the option to provide protection against a number of other diseases in cases of outbreaks or special situations, whenever, again, the risk from the disease is higher than the risk of the vaccine. We have a vaccine in development, the Group B strep vaccine, geared towards protecting infants against neonatal sepsis. And this is potentially a vaccine that could be similar to RSV, recommended for pregnancy for infant protection. And as we have heard, a number of opportunities for research, given the fact that there are many other diseases that do affect pregnant people and their babies, and that we need a way to provide some kind of protection to this very special population. The next slide is just to, again, give you a perspective regarding the complexity about this antenatal vaccination schedule that we now have in the United States. You see how influenza and COVID vaccines, which are mainly focusing on protecting the pregnant person against these infections that are particularly severe in the third trimester of gestation, do have a seasonality associated with them, but they are recommended to be given at any time during pregnancy. The Tdap vaccine, which is mainly focused at giving protection against pertussis, has a window of time, usually between 27 and 36 weeks, and it's also given at every pregnancy. And lastly, the RSV vaccine for protection of the infant also has a restricted period of administration between 32 and 36 weeks and a seasonality, so that it is given ideally before or right as the babies are being born during the RSV season. So there are a number of reasons why this is challenging, not only the number of doses, which could be an issue with acceptability from the mothers, but also the fact that providers, especially OB providers, need to provide information about all of these vaccines during routine antenatal care. In addition to that, the limited window of administration could be an issue if vaccines are not matching certain prenatal care visits. So there is no question that as we continue to grow this schedule, we need to adapt and be able to address these challenges. Next slide, please. So another complicating factor that we have is that, as you might have heard recently, also last year, we had an approval of a passive immunization product, a monoclonal antibody called nirsevimab, to be given to infants for protection against RSV. And similar to the vaccine, it does provide passive immunity. And the current recommendation is that both products, which are safe and effective, can be given to prevent RSV in infants infants, the vaccine for the pregnant person, and the monoclonal antibody for the baby. And that provides protection for about 5 to 6 months, the period of time when the baby is susceptible. But for the most part, you don't need to give both products to all pregnant people, because if the mother is vaccinated on time within that 32 to 36 window of gestation, and the baby is born at least 14 days later, they don't need to have nirsevimab. However, if there is no maternal vaccination, the babies can have this vaccine. So again, it's wonderful to have these opportunities. As a pediatrician, I can tell you how important RSV is in the first few months of life in terms of lower respiratory tract disease, pneumonia, and hospitalization. But we are placing a certain burden here for antenatal care providers. And with that, I do have to praise highly the role that professional organizations such as ACOG have had, and ACIP, of course, and the CDC. But ACOG in particular has been very active in providing not just their unequivocal support for maternal immunization and the use of these strategies, but also to educate their membership. Next slide, please. This is part of what the education entails. So in addition to talking about the products, talking about advantages, disadvantages, considering patient preferences, the local availability of the vaccine and the monoclonal antibody needs to be considered. And then either provide the vaccine during pregnancy in the office, which is associated with higher uptake, or providing a reference with a prescription so that the individual can go and receive the vaccine at a pharmacy. One other challenge that we have seen, given these new advent of these products, has been the need to document the vaccination in the pregnant person and to be able to have seamless information go from the antenatal care providers to the birth hospitals and then to the pediatric providers, so that we understand clearly who has been, or if there has been a vaccination given to the mother, and that then if it has not, and we are in the RSV season, either the birthing hospital or the pediatricians will have to take over and provide the monoclonal antibody. So linkage of the maternal and infant records continues to be also a challenge, even if we have electronic medical records, and also certainly providing documentation to the mother in paper could also be a solution to be able to have this information pass as it needs to go from different groups. The next slide is to tell you how we have come a long way in terms of research in vaccines in pregnancy, but also implementation of vaccines in pregnancy. And we have basically seen a paradigm shift where for a long time, there was actually exclusion of pregnant people in clinical studies. But certainly after especially the influenza 2009 pandemic, the realization that the benefit of interventions needs to be provided to the pregnant individuals also has resulted in a number of guidance documents that have become available. Some of this, including from NVAC in 2015, 2016, where the maternal immunization group addressed this particular need. And from there, you can see here some different documents from the WHO, from different groups that have provided guidance as well for implementation, how to implement influenza vaccine in pregnant people, for example, in the world and in some other countries. So that has resulted in better understanding, better awareness, and also communication tools that are available to us. The next slide is an example of that, as I was telling you about our professional organizations. And so here is, for example, the CDC and the ACOG resource pages, or some pictures of it, where you can find, for example, with the RSV immunization, slide decks or options for sheets that you can give as providers to patients so that they can be informed. And there's clearly a professional page where you can also have all the information you need. ACOG also has a nice maternal immunization practice advisory where you can see not just, of course, RSV, but all of the maternal vaccines. So I encourage everyone to take a look at these resources. The next slide is just to mention that despite the recommendations, despite the fact that we know that these diseases could have a significant effect in the morbidity and even mortality in pregnant individuals and their babies, and the availability of the vaccines, we see that year after year, the uptake remains low. This is the most recent data from CDC, an internet panel survey that includes data from 2020 to 2023. And you see influenza on the left and then the Tdap vaccine on the right as given to pregnant individuals. And you can see here, for example, that for influenza in 2022-23, only 47% of pregnant people received the vaccine, while in terms of the Tdap, it was 55%. Sadly, only 25% received both influenza and Tdap. So that means that 1 out of every 4 women are not being fully immunized with these very 2 basic vaccines. At that time, we also had COVID vaccine, and you can see that at best scenario in 2021, only about 1/3 of women received this vaccine during pregnancy. So I think that, as you can see here, we do have an important challenge because year after year, which is shown by these bars, there are also not just lower uptake, especially after the pandemic, but also disparities, racial, ethnic disparities that need to be addressed regarding coverage of vaccines during pregnancy. The next slide is to tell you that there have been already studies that have looked at what would be the contributing factors to improve this acceptance of vaccines among pregnant women, and what are the concerns that pregnant women will have. One of the main ones, as you can see from the patient perspective, is the safety of the vaccine to the baby. And the second most important piece is the provider recommendation, so that you do see the highest uptake in the bars there. You have flu in the dark blue, then Tdap in blue, and COVID in the lighter blue colors. That when the vaccine is given at the OBGYN or midwife's office, that is where you are going to have the highest number of people vaccinated. Now, from the provider perspective, we see that many times one of the concerns is just having the infrastructure to be able to provide these vaccines, having the time to counsel individuals about the vaccines, and certainly issues related to reimbursement or even concerns of safety liability of the vaccines. So this is well known, and I think that we will see more of these data coming along after the pandemic and with new vaccines being added, such as the RSV vaccine. The next slide is just to really summarize what we have seen. As a practicing provider, I have also been involved with some of the challenges associated with introducing the RSV immunization products last season to our hospital. And I think that some of the strategies that are important in terms of quality improvement relate to really being not just knowledgeable about these recommendations, but creating a culture of maternal immunization among all antenatal care providers and their staff. I think that we all have the best interest of the mother and the babies in mind. And by that, I mean both obstetricians, antenatal care providers, and also on the pediatric side, the pediatricians as well. So we do need to work together in terms of planning and coordinating how we take care of our patients and how we provide this information to try to lessen that burden and give that confidence to the patients about our recommendations. We do need to be up to date with the information. We need to have resources to give to patients and to their support system and be able to have a conversation to introduce these options at this time. I think it's very clear that vaccinating in the office as opposed to outside of the office is very important whenever possible, but that involves infrastructure, again, to have people in charge of ordering the vaccines, having enough storage space, having someone who knows how to manage and how to do accountability within the practice, addressing errors or preventing errors, and also addressing wastage and so on. So this is going to be something that I think for antenatal care providers, it's going to be more and more important to discuss. Who is going to do this? Who is going to talk to the parents? Who's going to be in charge of these things? Should they be dedicated personnel? One thing we did in our hospital as we were introducing these vaccines and pediatric monoclonal antibodies is to create best practice advisories so that in the electronic records you would have an alert indicating that this particular patient was eligible and could receive one of these vaccines. And if that was the case, it was offered. But there could be standard order sets. There could be other ways to try to improve the uptake. The documentation of vaccination, as we have seen, either through the electronic record or personal immunization records, is important. And I think that will reduce confusion because right now, many women are concerned or may not be very clear about what they have received. We've talked about linkage of maternal and infant records, all the communication that's important, and risk management as well to try to improve acceptance. Reimbursement is another issue, which I think should be discussed. Thank you so much.
Thank you, Flor. I appreciate your presentation. The next member of our panel is Dr. Courtney Olson-Chen from the University of Rochester. Dr. Olson-Chen, I see you on the video. Your slides are up. You have the floor.
Thank you so much. Thank you for the invitation to speak today, and I'm going to be talking about vaccine hesitancy in pregnancy. You can go to the next slide. So as you all know, vaccination is one of the most important achievements in public health, but the success of vaccination efforts has been challenged by those who question or refuse vaccines for various reasons. Vaccine hesitancy has been defined as a behavior that is influenced by a number of factors, including confidence, complacency, and convenience. And vaccine hesitancy is considered a complex issue that really falls along a continuum ranging from acceptance to refusal. The rise in the number of available vaccines has made this issue even more complicated. And in addition, global communication methods have expanded, leading to rapid sharing of public concerns and increased uncertainty. The behavior of vaccine hesitant individuals is complex, and the determinants of hesitancy are highly variable. Next slide, please. Recognizing the importance of vaccine hesitancy and its potential impact on vaccine coverage, the WHO Strategic Advisory Group of Experts, or SAGE, on immunization established a working group about 10 years ago, and they drafted this model of determinants of vaccine hesitancy that are based on their collective experience. And this focused on three major domains. The first was contextual influences, including historic, sociocultural, environmental, institutional, economic, and political factors. Second was individual and group influences, including those arising from personal perception of the vaccine or influences of social environment or peers. And the third area was vaccine-specific issues that are directly related to the characteristics of the vaccine or the vaccination process. Next slide, please. So to talk more specifically about pregnancy, there was an exploratory literature review done in 2018 that found 25 different barriers to accepting vaccines in pregnancy. And the most common, as we just heard, really were related to vaccine safety perceptions. Other frequently identified barriers included a lack of perception of being at risk of contracting the infection and also lack of provider recommendation. And in fact, healthcare provider recommendation was reported to be the most common reason for vaccine acceptance. In the chart, you can see the acceptance rates as reported by the CDC from the Internet Panel Survey mentioned in the last talk. And you can see the percentages among pregnant people receiving the vaccine. So in influenza, it was 48.4%, Tdap 45.8%, and COVID, at least one dose was noted to be 60.5%. Next slide. This is a forest plot from a meta-analysis performed in 2020 to further investigate the factors that influence maternal vaccine uptake. And I apologize for the slightly blurry appearance. This was the only available version of this figure, but to orient you, the factors that fall to the left of the dotted line are more predictive of no vaccination. And then the factors on the right side of the line predict vaccine acceptance. So here you can see that concern for vaccine harm during pregnancy was again found to be the strongest predictor of vaccine refusal. And in addition, vaccine side effects were another major concern that was associated with vaccine refusal. On the other hand, general awareness and information about the vaccine, recommendation from a healthcare provider, and history of receiving a vaccine in a a prior vaccine were all associated with a higher likelihood of accepting the vaccine. Next slide, please. This is from a national survey of more than 300 OBGYNs in 2016 that found that 97% of respondents reported strongly recommending the influenza vaccine for pregnant people. They perceived that more pregnant people tend to refuse influenza vaccine as compared to Tdap, and this figure shows the most common perceived reasons for refusal of the influenza vaccine. You can see that the top reasons were the fact that people thought the influenza vaccine would make them sick, the belief that they're unlikely to get the infection, the desire to have a, quote, natural pregnancy, and then as well as concerns about childhood autism as a result of vaccination in pregnancy. And of course, there's no evidence that a history of vaccination in pregnancy leads to childhood autism, but fears about this outcome are linked to vaccine refusal in the pregnant population. And this really underscores the profound impact that safety information on vaccines can have in influencing the decision of pregnant people. Next slide. This is from a multi-site cross-sectional study of pregnant people in the second half of 2020. So this was done prior to the availability of the COVID-19 vaccine. And they found that the majority of people were either somewhat or very worried about getting sick with COVID-19. And they also worried about a potential harm that COVID-19 could have for themselves or for their pregnancy. But despite this, only 41% of these people said they would get a vaccine if it became available. They expressed particular concerns about safety and efficacy of the vaccine, and they also cited a desire to protect their baby as the most common reason for accepting and refusing the vaccine, which is an intriguing dichotomy. Next slide. This is from another survey of pregnant people in California in December of 2020 and January of 2021. This was after the COVID-19 vaccine became available, and they found that 57% of people were hesitant to receive the vaccine. You can see some of the notable demographic and predictive factors, things like younger age, living in a less urban context, being an essential worker, having a history of COVID-19, and having no prior seasonal flu vaccine. Those factors all were associated with vaccine hesitancy for this COVID-19 vaccine. The most commonly reported reason for COVID-19 vaccine hesitancy was, quote, "I don't know enough about the vaccine," as low levels of self-reported knowledge were highly predictive of hesitancy. So this study concluded that decisions regarding delaying COVID-19 vaccine were largely based on lack of knowledge about the potential impacts of the vaccine on the pregnancy and the fetus. Next slide, please. We performed a qualitative study of semi-structured interviews of pregnant people to better understand beliefs and attitudes towards the COVID-19 vaccine. And this figure shows some of the themes of those people who expressed hesitancy to receive the vaccine. The primary themes for unvaccinated participants were concerns about the paucity of research on the vaccine and the potential impact on both fetal development and maternal health. So while the participants identified healthcare providers as the most trusted source of information about vaccines, most of them said that the internet was their primary source of information. One participant expressed concern about the information she received from her clinic. She said, "So here at the clinic, they gave me these article links and I read them. And at the end of every one, it's like, there's not enough data to give you enough information about pregnant women taking the vaccine." Others expressed concern about the potential implications of the vaccine for childhood health. I apologize. Saying, and I think, yes, it might be safe, but now, 5-10 years down the road, another person said, "It makes me nervous because there hasn't been pregnant people yet who got the vaccine and have a kid who's like 5. So I just don't feel it's safe while I'm pregnant. I just worry that later on, there's going to be some type of data that it causes like autism." Next slide. We just saw these graphs in the last presentation, but this shows the data from the CDC of the yearly internet panel survey. And you can see that there's been a decline in overall flu and Tdap vaccine coverage over the last 3 years. Receiving both vaccines is even less common, and those numbers are down over time as well. This data also demonstrated racial disparities in vaccine coverage. In 2022, flu vaccine coverage was highest among Hispanic women, while Black women had similar coverage to that as of white women. Tdap coverage was lowest among Black women. The most prominent decline in vaccine coverage over the last few years has been among white women. And this may be impacted by the behavioral and social drivers of COVID-19 vaccine concerns that have then influenced feelings about other vaccines. Next slide. This is data published from a survey in 2021 that found that compared to white pregnant women, Black pregnant women were significantly less confident in the safety of either flu or Tdap. They were also less worried about getting these about getting these infections. And they had less trust in the information provided by either obstetric healthcare providers or federal agencies. Black pregnant people were significantly less likely to report that their friends and family would receive vaccines in pregnancy. So it's clear that social norms are also linked to vaccine acceptance. Next slide. Quinn and colleagues aim to better understand flu vaccine uptake among and within the Black population. So in this figure, you can see there's no single factor that's responsible for the observed racial differences in vaccines, but instead there's a lot of pathways that function simultaneously to contribute to the differential vaccine uptake. And they found a lot of diversity within the Black community related to influenza decisions, highlighting the need to continue to break down each person's knowledge, beliefs, and attitudes. Next slide. As we'll continue to hear about today, there's many opportunities to, increase maternal vaccination rates in pregnancy. Provider recommendation is critical, and frequent office visits naturally occur in pregnancy, so they do allow for more opportunities for provider counseling. Having vaccines available in the practice makes it easy for our patients to access them. But communication training for obstetric providers is needed to address patient concerns and hesitancy. So perhaps this should be targeted to specific individual concerns, and more than one approach is likely needed to really have a dramatic impact on the rates of vaccines in pregnancy. Thank you, and I apologize for losing my voice.
Thank you very much, Dr. Olson-Chen. Our final presenter in this panel is Dr. Kevin Alt from Western Michigan University. Kevin, your slides are up. I see you on the screen. You have the floor.
Thank you for that introduction. May I have the next slide? Similar to the prior speakers, I just want to make you aware of these potential conflicts of interest. I've recently joined the board of directors for the National Foundation of Infectious Diseases. I'm going to kind of finish one of my last slides with a little shout out to them. So next slide, please. This is data that you've seen presented a couple of different ways, and my other speakers, my colleagues, set me up very well for success here. So these are two different data sources, the MMWR that was published in the fall of 2023, as well as the live data that's on the COVID VaxView that you could look at on your phone while I'm talking. But I think there's something striking about both of these data sets, and Dr. Olson-Chen actually mentioned some of these things. 60% of women, you could see as you look at that upper panel for the MMWR, received vaccine when they were pregnant or before they were pregnant in 2021 and 2022. However, that 40% number of unvaccinated women did not waver through those 2 years. And the thing that I remember about those 2 years was making trips to the intensive care unit. I think our other panelists, their obstetricians, probably had that experience. Unfortunately, those very unhappy trips to take care of critically ill women. At our national meeting in the spring of 2022, we had a speaker from the University of Missouri that talked about, or I'm sorry, the University of Mississippi, that talked about her local experience in her ICU literally being filled with ill pregnant women from COVID. But despite all of that happening in 2021 and 2022, including recommendations from ACOG and many other professional organizations, that number did not budge. I was a member of the ACIP from 2018 to 2022, and one of the things that we struggled with was the complexity of the recommendations around COVID vaccinations. So last fall, when the 2023-2024 version was recommended, it was going to be very simple. You were going to get one dose while you're pregnant, and I was very optimistic at that time that would help us raise the immunization rate in pregnancy. Unfortunately, I was overly optimistic. The blurriness of my screen capture may be helping me here because this data is kind of depressing. The top of that bottom panel is 25%. As you can see, going up into the end of January, we don't even quite get to 25% coverage in the vaccine safety data link system, which is about 3% of the United States population. I'm sure many of you are familiar with that. It also is an insured population that has a very robust system for preventative care, and we still can't get to 25%. The other speakers, many other speakers today have mentioned this, but this is also something that I wanted to talk about. That green line at the bottom are Black Americans in the VSD system. As you can see, barely even registers there to get to 5%. So next slide, please. This is a great segue or other people gave me a great segue to this slide. This is actually based on a meta-analysis of 321 studies that have been done in the 15 years since the 2009 pandemic. And almost everybody else that's speaking today mentioned this. So strong provider recommendation and access to prenatal care, as you heard in Dr. Olson-Chen's discussion, are probably the two strongest predictors. And when I say access to prenatal care, that also means in-office vaccinations. So you also heard other speakers talk about focus on vaccine safety as far as a method to improve vaccine uptake and infant benefits. All four of the vaccines that have been mentioned previously that are recommended during pregnancy have an infant benefit. This also reflects my personal take on this as well. I'm talking to pregnant people. The very first person when the RSV vaccine was approved that asked me about this was somebody who had had a prior child that was affected with RSV. So the very first discussion I had about the new RSV vaccine was with a pregnant person who had unfortunately had a child that was hospitalized with RSV and brought it up before I could even get it into the conversation. This is really a well-done meta-analysis. As I said previously, about a third, this is an international meta-analysis, about a third of these studies are from North America, and they heavily emphasize flu and Tdap. So they might be getting a little dated, and I'll talk about that towards the end of the talk. So next slide, please. This is another meta-analysis, and I like this diagram because it kind of talks to me about the kind of both from a research angle and an implementation angle in our own health systems and offices, how we can implement these types of changes to increase vaccine uptake. You can see the blue text are things that I put on there: patients, provider, and practice. And I think when you think about breaking down barriers to maternal immunization, that will help you. The two authors of this meta-analysis were a little more elaborate, but the reason I like this Venn diagram is the overlaps between some of these. So Dr. Munoz did an excellent job of talking about health system improvements And those would be practice improvements. And as she mentioned, and other speakers have mentioned, there are data for standing orders for on-site immunization. There's mixed data on texts to patients, but now that's more sophisticated. So I think later studies probably show more influence of direct messages to patients. In my medical records system, electronic medical records systems, all the reminders for preventative health are in the lower left, and you can program them to do a pop-up. And I've done a study, and other people have done studies that have shown that increases maternal uptake, or increases rates of maternal immunization. So since this study is a little older, this meta-analysis is a little older, we didn't really, and none of these meta-analysis I'm going to mention really mention pharmacists. And that might be one of the good lessons that we learned from the pandemic, is that pharmacists really can be our partners for maternal immunization. And you saw a little hint of that in a prior slide that was shown. So I mentioned providers already on the previous slide, and there's lots of overlap between this slide and that previous slide. However, providers is probably more of a global and holistic type of meaning as far as everybody that interacts with your patient. It's hard to overcome a patient that's heard something negative about a vaccine from one of your colleagues that work in your office when you're the provider. So these office-wide and system-wide education efforts, not just for midwives and physicians, but also for everybody that might come in contact with a pregnant person. And that upper part is patients. We mentioned a lot of this already when we talked about vaccine hesitancy. Knowledge is certainly of these vaccines is certainly one of the things that works in our favor. One of the things that we're going to have to think about when we think about future research, and as well as what happens in your office, and again, Dr. Olson-Chen mentioned several times, is countering misinformation. It's hard to keep up on what the latest flavor of misinformation is, and so that's a little bit of a challenge, but more developing that trust so that you can counteract that as well. So next slide. This is a slide or an intervention that I borrowed from Dr. Chamberlain's 10-year-old study that looked at Tdap and flu. There are a number of similar studies that look at HPV vaccination for non-pregnant people, but also in OBGYN offices, and they all seem to have similar themes. And the other study down there, Healy et al., is a very similar study to this. So we've already heard about office vaccine champions, and champions are only knowledgeable. They know all the logistics. They know what temperature the freezer is supposed to, or pardon me, what temperature the refrigerator is supposed to be at, where the vaccines are, when they expire, where the logs are, those type of things. And putting one person in charge of that has really been shown to increase vaccine uptake, because you have a go-to resource right there in your office. One of those studies at the bottom specifically looked at toolkits, and Dr. Munoz mentioned this a little bit because ACOG has produced for us both talking points and toolkits that we can use in our office, as well as brochures, posters, lapel pins, and other things that we can use. Some of those are probably also in your own healthcare systems. One of the things that is in most of the later studies, or beginning to be more widely studied, is videos. In the Chamberlain study, there were videos on iPad, and patients could relate to those more. And as we, of course, get into more generation of pregnant people that are comfortable with electronics, that is both a proven benefit and a area for future resource as well. When we do these interventions, we can expect increased vaccine knowledge among our pregnant patients, trust in the information that they receive from us, and reduce safety concerns. And there are data that these types of multi-interventions achieve all those aims. I think there's a fair amount of data, and I'll be curious what the other panelists say, that, especially Dr. Munoz, that this spills over into the recommended vaccines that children get the first few years of life. Next slide. You've seen this data a couple of times, both in pregnant and non-pregnant adults. Maternal immunization and uptake of vaccination recommendations is certainly a health equity issue. I made this slide based on the data that's in the MMWR at the end of September last fall. You can see that our Black communities are lagging behind as far as uptake of these vaccines. This probably has an even more ominous overtone for my specialty, maternal. There are health disparities in maternal mortality. We had about 400 maternal deaths in the United States, which is about 40% of all the maternal deaths in the year 2021. Maternal mortality reviews usually done state by state, and so that data is beginning to trickle in. And there are many preventable deaths due to COVID. Most maternal deaths are preventable, but there are vaccine preventable maternal deaths as well. We saw this in 2009. In that calendar year, about 10% of all maternal deaths were due to influenza in 2009. So we've seen this history previously, unfortunately. Next slide. This is an overview of some of the things that Dr. Olson-Chen already mentioned. However, I think the thing that's a little different from what she said in this review article is that it mentions some things that we can do. These are not really practice, provider, or patient type of things. They're more community oriented, so they get into implementation science as well as reaching out to potential resources in your community. When I show this slide, I'm always reminded of Tip O'Neill in the 1980s, who used to say, all politics are local and probably all solutions for this problem are local as well. So, but as far as solutions, peer-to-peer communication, as well as using the resources that you have in your community. This includes prenatal classes and doulas that you may use, outreach as far as town halls with pregnant minority patients that include medical providers that they can relate with, open discussions on social media platforms. We have a physician in Flint, Michigan, on the other side of the state from me, who unfortunately had a death in his family due to COVID and had no experience in social media and just started recording videos. And the obstetricians, the OBGYNs on that side of the state said that his message was really powerful as far as resonating with that, and had no experience with social media. I think that was a great story that I heard fairly recently at the Michigan ACOG meeting. Community engagement to talk about the benefits of COVID vaccination, as well as dispelling some of those fertility myths that we heard in the previous talk. And then also, again, kind of talking about future research, setting an agenda that will work with these community groups, not only to do short-term benefit as far as maternal immunization, but also to look at ways that we can develop those partnerships for some of these future vaccines that Dr. Swarmy mentioned. So next slide. This is my little shout out to NFID, and it does come back to what some of the other speakers, especially the first talk, mentioned. So last fall was the 50th anniversary of the founding of the National Foundation for Infectious Diseases. And Dr. Baker and I happened to walk in at the same time for this. And I mentioned to her that in 1989, when I was a resident, I gave a journal club about her New England Journal of Medicine article about Group B strep vaccine. And now we're on the cusp potentially of having that vaccine and a CMV vaccine. So potentially in the next few years, we could be talking about 6 vaccines to be given during pregnancy, and other people have mentioned that. So I think that even though I gave you those wonderful meta-analyses and reviews, I almost wonder if some of that research needs to be redone or maybe even thrown out. It's become more complicated, especially when we start talking about 2 more vaccines into that schedule. And we have different ways of preventing RSV, and we had a bit of a stunted rollout for those prevention measures. But rather than pontificate on those type of things, I will quit talking, and I'll be interested to hear the opinion of other members who are listening in.
Thank you so much, Kevin. I want to thank all the members of this panel. Are there any questions or comments from members of the committee? Jeff Dushin, please go ahead.
Thank you, Dr. Hopkins, and thank you to everyone for these great presentations. They all have so much good information on how to help improve vaccination rates. I'm curious about one thing. You know, we've heard a couple of times that Black women in particular have low uptake of recommended vaccinations, and there's a lot of strategies that have been suggested around information, provision of information, and culturally competent communication and so on. No one has mentioned improving the number of Black physicians, and in particularly the Black OBGYN. And I'm wondering if that should be part of our strategy. That, you know, they're underrepresented, like less than 6% of physicians are Black in the US. 12% of the population is Black. And I think Dr. Ault can probably tell us more precisely what the ratio of Black OBGYN are to Black patients. But I'm wondering why that isn't on the radar. Thank you.
I think that is on the radar from ACOG at a national level. I mean, I think this is my opinion without data, so I'll be curious what my co-panelists say. You know, we do have a diverse group of young people, of medical students and residents in our specialty. We need them to, I think one of the problems we have in our specialty is we tend to lose them as far as an asset the first few years out of their residency. And we talk about this a lot at our national meeting. And of course, those are the assets we need to engage in these community efforts that I previously mentioned. And so I think we have good or at least representative diversity in the younger levels of our trainees. It's just to kind of keep them engaged, I think, is our problem. And I'll let other people talk to that end. So
yeah, I guess I might add one other thing to that, Kevin, is that, you know, the provision of obstetric care is expanding well beyond OBGYNs as well. You know, so thinking about who pregnant people are interacting with. So certified nurse midwives, our doulas, other support personnel, advanced practice providers beyond midwives, such as PAs and NPs. I can tell you, even in our high-risk maternal fetal medicine practice at Duke, we employ a significant number of advanced practice providers because we simply have to, you know, expand the coverage that we can provide. So I think it goes well beyond just MDs. And to come back around to the fact that at present, I think you saw some of this data as well about provider recommendation being so important, yet we know that vaccines that are now recommended are not being stocked in all of those OBGYN offices. It has a lot to do with cost, reimbursement. Most OBGYN offices are not part of Vaccines for Children to give those vaccines for anyone less than 18 because of a lot of the obstacles that come into that. So I think while it's true that we should be thinking about how our provider population looks relative to our patient population, I think keeping in mind who is actually also providing that care is important as well.
I had group prenatal care in my potential solutions too, and I think I forgot to mention that, even though I had it in my notes.
Yeah, so centering pregnancy and
Right.
other models in that, as well as, you know, some of the models looking at combining prenatal care and pediatric care, right? Looking at this as a co-managed effort between obstetrics and pediatrics. We know that that also, given the Medicaid expansion that is happening in most states to provide care to women for 12 months postpartum, we should really be thinking about how we're combining that. So again, we're not in the, we're sort of passing back and forth, right? Like Floor obviously is hoping that we're talking to our patients about RSV vaccine. We're hoping that Floor is talking to patients about what RSV is, because as obstetricians, we're not even seeing it, right? So how do we make sure that we actually connect on all those fronts as well?
Thank you for those responses. I'm very interested in the non-physician healthcare provider piece, which is really important. Is the racial breakdown of non-physician providers more representative of the population than that of physicians?
I don't know it well enough, Jeff, to say, but I suspect that it's similar. I will say, I think in the space of doulas, that there is a significant effort in looking at diversity. I do think that there are specific groups focused on both the group prenatal care and in doula care or doula services that are looking at that by race and ethnicity as well.
Thanks again for your replies.
Mm-hmm.
Well, I want to thank the members of this panel again. We are all in this together. I'm putting my internist hat on one side, my pediatrician hat on the other, and saying all of this are working together on better vaccinating our pregnant patients and the rest of their families to try to reduce the impact of these vaccine preventable diseases. I want to thank you again for your presentations, and we will move to our next panel.
Thank you.
Our next panel is titled Inclusion and Immunization, Special Practices for Special Needs. In the last panel of our meeting, we'll hear from Dr. Allison Bray and Jessica Peck from Baylor University, Dr. Anna Taddeo from the University of Toronto, Melanie Hoyanowski, Eden Baker, and Allison Tappan from Children's Hospital of Philadelphia. These speakers will provide presentations on ways they encourage inclusion by using, studying, or teaching special practices for people with special needs. This is the second panel NVAC has held on this topic. Certainly a very robust discussion and presentation at our last meeting in September on this topic, and very glad that we can continue the discussion today. Dr. Bray, are you on? I see your face. Your slides are up. You have the floor.
Okay, great. My colleague, Dr. Jessica Peck, is on as well. So she and I are going to start this presentation off. We're excited to be here. Thank you for having us. Jessica, are you on?
I am here. Hello.
There you
everyone.
are. Okay.
So we'll tag team a little bit. We're very grateful for this opportunity and to talk about this really important topic. And, when we're looking at, you can go ahead and advance to the next slide, if you will. That would be great. So when we talk about strategies, obviously, we really care about pediatrics, a preventive lens, and from a wholeness lens, from a holistic care lens. We want to meet their holistic healthcare needs. And a lot of that, we're seeing so much more emphasis now on health promotion and wellness rather than just treating things after they come. And it is really important in pediatrics to provide that safe, trusting environment. And I think one of the things that we're talking about in the pediatric community as a whole is the disruption of the care continuum and the loss of that relationship with a primary care provider, going to seek places like urgent care or telehealth, which have their place and access to care, but we worry about, what does that mean for providing that safe, trusting environment where parents can come in concerns and their questions and interface with a healthcare provider who they know and they trust in making decisions about their child's health and specifically about immunization. It's important as pediatric care providers, we recognize those and cognitive differences that kids may have, and we do consider physical and social that may be unique to those families. And one of the things we wanted to bring up is identity first language. Now, many of you are likely familiar with this, but in case you're not, there are some within the disability community who a person language. That's the emphasis that we see generally across our sessions, saying children who have children with a certain condition. But there are some people within the disability that oppose that, and they believe that if language is needed to separate them from a trait they feel like is inherent to their identity, it suggests and implies that that trait is negative. So they may prefer to use identity first language. So as we're trying to be sensitive and say you have a child who is deaf, I just want to say, no, my child, identify as deaf or identify as autistic. Those are two that we see that are more common there. So that's just something to consider. Go ahead and go to the next slide.
Jessica is frozen.
I'm sorry?
I think you froze there for a moment.
Oh,
Jessica.
no. Okay. I'm sorry about that. The joys of technology. All right. The Maternal and Child Health Bureau defines children with special health needs as those who have or are at increased risk for a chronic physical, developmental, behavioral, or emotional condition and who require health and related services of a type or amount that is beyond that required for children generally. When we look at challenges that kids with special health needs have, we know that there are challenges to vaccinating. We know that about half of parents have trust in their local health department or a high degree of that in the CDC, the American Academy of Pediatrics, or the vaccine development process. We see, of course, less than half of US parents reported themselves as likely to have their children vaccinated against COVID-19. And about a third of parents said they are unlikely to have their children vaccinated. And as health providers, we know that it takes a lot of time to discuss any parental vaccine concerns, and that can be a significant barrier to practice. Next slide. This next slide speaks to children with physical disabilities, neurologic, neurodiverse children, or autism. About 3 million children in the United States have a disability. This accounts for about 4.8% of children under 18 years of age. And they're 3% more likely to have allergies to food, latex, and microbials. And some of the psychosocial challenges that we see related to the COVID-19 pandemic, we see increased use of PPE. For a while, really difficult, especially for children who already had fear or anxiety, and now they're coming in and seeing someone like Baymax from 6, and they don't recognize that person. Or these just examples of some psycho and physical contributors to considerations we have for barriers for immunizations. And the American Pediatrics recommends children must be vaccinated following the same schedule unless they are medically contraindicated. But again, preventive can be for children, physical disabilities, neurological or neurodevelopmental disorders. And we know that those children are at higher risk in many.
Jessica, you have frozen again. I don't know if you can hear us, but you may want to take yourself off video just to see if that helps.
I'm not sure what happened, where she went. Well, I can pick up because actually I was going to do the next slide. So you can go ahead and advance that, please. Okay, so what I want to do is go over some of the physical challenges that children with special healthcare needs, some things you must consider, when vaccinating these children. We know from a long time ago that egg allergy was considered a contraindication, but of course, no longer it is. That has been decided that children that receive the influenza vaccine, MMR vaccine, yellow fever vaccine, are actually okay to get those vaccines if they have an egg allergy. So unless there is, of course, a documented anaphylactic reaction, then certainly we would not give them one of those vaccines due to the egg allergy. Gelatin, which is a stabilizer that's found in your measles, mumps, rubella vaccine, the MMRV, the Proquad, and the varicella vaccine can also cause hypersensitivity to some children. Those children with the severe cow's milk allergy may have a problem receiving the DTaP, the Tdap, the oral polio, which obviously we are not doing anymore, or Hep B may find themselves having trouble. And then, as Jessica mentioned earlier, the latex concerns. Interestingly, those children that have spina bifida or cerebral palsy, due to how many times they have probably had surgeries, and this goes for any children that have had multiple surgeries, is you have to worry about latex. And so clearly using latex-free gloves, switching to nitrile, or making sure that your syringes do not contain latex as well. So go latex-free in your practice. Next slide, please. Let's go over some psychosocial challenges a little more in depth with these children with special needs. The increased use, as Jessica mentioned, of PPE, or the personal protective equipment in the hospitals and the clinics. This actually has reduced, children rely on facial expressions and that thing as they're communicating. And so they view that as reduced communication, and it can increase their anxiety among these children. And patients and parents, as we know, they base their initial perceptions of pediatric providers, and any providers for that matter, on their attire and their facial expressions and their body language, which can affect the patient's comfort level and their ability to cooperate. So the PPE, as we found, was so increased starting in 2020, it's been found to cause some problems. These children are also more likely to externalize the behavioral manifestations of anxiety than children without disabilities. So this particularly can be a barrier when you're immunizing these children in your practice. Next slide, please. So here's some interesting information that we found on minimizing the stress of immunization in your practice. Clearly, of course, you want to develop a trustworthy and honest relationship with your patient and your families. Interestingly, there are some distraction techniques that are mentioned throughout the literature. Some easy things to incorporate, such as blowing bubbles or using the pinwheels where you just blow on them, deep breathing exercises, and one of my favorites is music therapy. We use this a lot in the operating room as well. I know that's been studied quite a bit, but it also is therapeutic, during stressful situations in a pediatric practice. One of the most interesting things that we found was the use of social assistive robots, also known as SAR. These can interact with the child, they can capture their attention and kind of redirect their focus toward more interesting objects. And some have even, the more higher technical ones have shown some empathy. So the children enjoy. I have not used this in my practice, but I think it's a pretty neat device that could be used. Something as simple as squeezing a ball just to distract and take their mind off of it. Thermomechanical regulations such as cold therapy or vibration therapy. Buzzy, I believe, is the one that a lot of pediatric practices and hospitals use as to kind of minimize their stress and anxiety. And of course, we would like for them to not be on technology as much as they are, but streaming movies is another, or having them play video games on an iPad or something in the office is also something that can help. Next slide, please. Another important thing to consider with children with special needs is positioning as you're doing these vaccines. It's been found that the upright rather than lying down position, the upright sitting position, is greatly going to increase their sense of control, as well as, rather than just setting them up on the table, have them sit in the parent's lap, either facing the parent or turned and facing you as they're getting the vaccines. Gives them that sense of security. And certainly, as far as restraints, it needs to be the least invasive. You want to use the minimal amount of time and minimal force to have the best success rates. Okay, next slide, please. And this is Jessica.
Okay, and I'll take this one. And Dr. Bray, if I freeze, you just take it away for me.
I will.
Okay, we wanted to bring this up because this was brought up by the planners that it was a point of discussion at your last meeting, but we had some considerations for pharmacists because there is an access advantage because most of the US population lives within 5 miles of a pharmacy, but this is within pediatrics when in 2020 Act authorized pharmacists and technicians to give flu and COVID vaccines. Although of course that varies by state law. And there were some pediatric care providers who were concerned, again, what I said at the beginning, that that could disrupt the continuity of care. And so that is a concern. Although pharmacists have been giving vaccines for a long time, their first formal training, as you can see, wasn't until 1994. And I looked at the training program, which is a training certificate program. There are 20 hours that cover various topics, but there's a lack of content addressing children with special health needs, and they may have specific needs, and that may present those needs may present specific barriers in a pharmacy situation. So there is opportunity to collaborate with local pediatric providers, especially for those children or for increased education. And our biggest advice is just respecting the family as experts, especially children with special health needs. They know very well how their child will respond and what will work. And so collaborating with the family and leveraging their expertise and their child with your expertise in administering vaccination can be helpful. So with that, that is our time, and we'll give it back over to you. And we look forward to questions and discussions.
Thank you very much, Allison and Jessica. Our next presenter is Dr. Anna Taddeo from the University of Toronto. Dr. Taddeo, your slides are up. I see your face. You have the floor.
Thank you. Thank you, everyone, for inviting us to speak. I very much also enjoyed the previous presentation, so thank you for that. And I'm going to pick up on some of the ideas that were shared as well and talk about our CARD program, which to my knowledge is the first framework that's been created that's evidence-based to help providers systematically integrate research evidence about pain care into how they plan and deliver vaccinations. So next slide, please. Here are my acknowledgements. Next slide, please. I want to talk about two things. So firstly, briefly, why addressing vaccination pain and associated symptoms is important. And then secondly, talk about the CARD program or protocol, and all these names work, or however you want to call it. And we'll talk a bit more about it in a second. So next slide, please. So first about vaccination pain. Next slide. All of us know that pain from vaccine injection is the most common adverse event following immunization, even though we don't call it as such. Pain is, as we know, an unpleasant sensation, very subjective, so everybody feels it differently. For children, they perceive needles as more painful than adults, and they're more bothered by them. They anticipate the pain, and this can make them be afraid and have anxiety. And if they have such symptoms, it also leads to other stress symptoms like dizziness and fainting. Importantly, fear and pain have a reciprocal relationship, so one can escalate the other. So if you have more fear, you actually experience more pain. If you experience more pain, you then have more fear. And as we have more and more injections being added to the vaccine schedules, there's more and more opportunities for people to become afraid of needles, and then for this needle fear to stay with them and to not go away unless it's addressed. And concern about pain and fear, therefore, has the potential to affect people's behavior. Across the lifespan, we estimate that about 1 in 10 people is under-vaccinated because of concerns about pain or fear. At this point, we don't systematically integrate evidence about what we know about how to reduce these types of side effects during vaccination, even though there's a ton of research about it. We use it more towards a one-size-fits-all approach for our vaccinations. And the CARD system is a new framework to help us to integrate this information systematically in how we deliver vaccinations. Next slide, please. So now let's talk about CARD. Next slide, please. The CARD system was developed from a clinical practice guideline that we published in 2015 that covers this information. So what it does is essentially operationalize the clinical practice guidelines. So clinical practice guidelines tell us what we're supposed to do, what the evidence says works, but a lot of them fall short with the how exactly are you going to do this? How do you integrate all this information all at the same time? And the CARD system is what that is. So as I said, it can be thought of as a protocol or a framework, but some tool that helps us to get this evidence into action. And it involves everyone. So it's not just for the provider, it's also for the patient. So it invites the patient to be able to make decisions about the aspects of vaccination that they can control, that we don't have to control as providers. So they pick their coping preferences, and they also ask us whatever questions that they need to ask us. So if we go through CARD, as you see here fanned out, we literally talk about this as people playing their cards. All the different letters of the word CARD stand for a group of interventions that people can play or use to help them with their coping. C stands for comfort, A is for ask questions, R is for relax, and D is for distract. And you almost don't even need to know what the guideline says if you know these 4 words, because they already give you a lot of insight about what we can do to make people more comfortable during vaccination and reduce these side effects. So in all the places where we have evaluated CARD, so even though CARD itself is evidence-based, we've actually created evidence from implementing CARD to show that it works. And we've used it across different vaccination settings, including school-based vaccinations, which you all know we do in Canada, pop-up clinics, mass vaccination clinics, community pharmacies, and hospitals. Next slide, please. So here's a little bit more about how CARD works for the different groups. So if you're a patient, look at the left side. You basically need to know what CARD is. You need to know what all these letters stand for. And we teach people this. It's very easy. We give them some suggestions. So what Allison was talking about, some of those options, for example, for kids who are autistic, we would customize the options for those groups, and they would choose from that list what they would like to do. So the important point here is that we actually educate people about what the options are, and we give them the choices. We don't decide for them what we think that they need. So we invite patients to participate. If you're a provider, you look on the right side of the slide, and you need to know a little bit more than just CARD. You need to know this 4E model or framework that basically helps you to support patients when they make their choices, but also integrates other research evidence that you're in control of that the patient is not in control of. So this is like a protocol or a toolkit that you can follow. Next slide, please. So a little bit more about this 4E model. If we go from left to right, starting with education, obviously we need to teach people this stuff, and we can do this on the spot, and we have, and it works. We can teach providers and literally transform spaces and processes in less than half an hour, and we can teach patients. We can do this ahead of time. We can do it on the day of the procedure, and we've done both, and they both work. If we go to the next section, environment. Oh, sorry, go back, Anne. I'm sorry. Just want to go through a few of these, if you don't mind, if there's time. And if there's not, let me know, and I'll just skip over them. But for environment, we're looking to make spaces for vaccination more comfortable and more inviting. We're looking to reduce fear cues. So you see in the box on the right beside the word environment, some examples of things we can do. And I want to point out distractions. We all know that this works, but we use distractions in waiting areas as well, because this is when people also tend to become more anxious, particularly children. So if we give them something to do and it's something fun and they feel comfortable with, then this really relaxes them for when it's time to be vaccinated. If we go down to the bottom right, you see the word engagement. This has to do with how we talk to people. So talking to people in ways that promote coping, rather than promoting distress. So we can give providers some hints and some tips about things to do and things not to do. And a big part of this engagement part is also how we interact with the patient. So inviting their participation, getting them to tell us and show us the things that they want to do, and then supporting them in their preferences. And then finally, evaluation, something we don't do too much of, but asking people how they feel, and logging this and using this information to refine for the future. So we typically do things like say, hey, how did that go? Was that okay? And people say, yeah, it was fine, was okay. But that's not very useful. That's not a very scientific or valid way of asking for feedback and finding out what's really going on. So we ask people to tell us, how much did it hurt? And we quantify this. So we measure this in scientific ways, and this really gives us insight to know how well we're doing, and we otherwise don't have this information. Next slide, please. So here's CARD in action, same stuff. The 4 E's are across the top. You're educating people, you're creating spaces and also processes to help support people. And then you're evaluating what's happening. And there's a feedback loop to make sure that what you think you're doing, you're actually achieving. And I'll give you an example is when we've done projects, providers will tell us, oh, we hide the needle. We don't show the needle to kids. And then we get feedback from the kids on their surveys that say, I saw the needle. So really easy things that we can change and fix just by asking people what they think, and stuff that you can make a significant impact just because you had no idea that something was happening because you never asked anybody. Next slide, please. So if you just click on these slides, so I'll pull up some pictures if that's okay. So just to show you in each of these E letter categories, some of the tools and resources that we use. We have webinars, we have e-modules, we have guides, videos that we teach providers with, and as well as students. So pharmacy students were mentioned, the e-module that you see a screenshot of on the right top, or it says, I can't even see what it says actually with my screen, but something about improving your vaccination experience. We show that to pharmacy students when we train them about vaccines across different universities in Canada. So they're learning about this stuff. And if you click on the slide again, you'll just get some quotes that different learners have told us. So one is bringing attention to something they never thought too much about because it wasn't really something that was ever focused on, and that is the patient experience. And then teaching people skills that they are not learning elsewhere when they're learning about vaccination. Next slide, please. Again, if you just click on this slide, I'm going to just show you one of the tools that we use to educate patients. And this is the CARD web game, which we use in kids between the ages of about 5 to 12. There's 2 parts to the game. The first part is to teach kids a didactic part about CARD. So they learn the acronym too, just like adults, and they learn what the coping options are in the different letter categories, and they can make choices themselves about the stuff they want to do. And then the second part of the game is that they can actually play the game during the needle procedure. So there's a distraction game that this child is playing right now, and she's 5 years old. And there's other games that actually help to build skills like deep breathing. Next slide, please. When it comes to environment, I mentioned distraction. It's huge. It's huge, not just for children, by the way, but for adults. Really, really makes a difference for people of all ages. So we have an example of some of the distractions we use on the left. We use a distraction cart usually when we can, and we wheel it around in waiting areas. And then we have distraction items that we also include in vaccination spaces. And what we include depends on what we can include, what the age range is of the person that is being vaccinated, and other factors as well. And I've put in here on the right numbing cream or topical anesthetics just to remind me to say that, because that is important in terms of equity, being able to provide that for people. It doesn't really cost a lot of money if you buy a big tube because you get tons of doses out of it. Not everyone wants it, but for the people who do, it can really be the game changer and the difference between them getting vaccinated or not. Next slide, please. These are some vaccination spaces. We vaccinate, as I said, at school across Canada. These are just some spots in schools where spaces were converted to be able to deliver vaccinations. So on the left, you can see that some privacy was created around a table by putting a board so people couldn't see other people getting vaccinated, and there's a large space between the tables. And also importantly, I want to draw your attention to the orange chair, which is facing outward, which is where the child sits. So they're not actually facing any equipment or anything scary. They're facing other distractions, which you can't see in this picture. And on the right, same thing, the child's not facing the table where all the equipment is. And there's even a little board that kind of separates what's going on. And she's able to have a support person here, her friend who's sitting beside her on the right. Next slide, please. These are all easy things, obviously, to do. Doesn't cost money. It's just a different way of doing things and being a little bit more purposeful with how we arrange the spaces. So now to move to engagement, one of the other domains, the 4 E's of CARD. Engagement is about how we talk to people, how we interact with them. And the biggest or the most important tool that we use is the card checklist. So across all ages, we find a way when people register, when they come to be vaccinated, to show them this that gives them the options for how they would like to cope, how they would like their appointment to go. And it's about stuff, as I said, that they can control. And there's different versions of the checklist depending on where we're working and what the population is we're working with. And I'm just showing you 4 of them, but there's dozens of them. So on the left, for instance, this is a version that was used by one of the hospitals in Toronto during the COVID pandemic when they were vaccinating people who identified as having high anxiety or needle fear. And the second one is one we used in pharmacies and community pharmacies. And in both of these, one of the options that I want to draw your attention to is we asked people if they wanted us to leave alcohol wipes out of the vaccination process. So all of you know that wiping the skin with alcohol is not a necessary part of the procedure, and it can make people more anxious, also creates a lot of garbage, and it wastes time. So you can literally save a minute per interaction just by not doing the alcohol swab. Most people, when you give them that option, they actually say, yeah, I'd rather not have it. So that's part of what was on the checklist, but obviously the options are going to vary depending on what people want in those contexts and what we know about them, what we can offer, that sort of thing. And if we continue on the right, you see a version of the checklist that was created for, we forego the alcohol swab. So we can talk about that if people are interested further. COVID-19 vaccine, we have a version for Muslims. We worked with our colleagues, and you can see there some of the options are a little bit different, customized to people who might be thinking about things differently. So what does relaxation mean for them? So this is really important to find out what people want, what choices they want to make, but we always have an option for people to tell us if there's something not on the checklist that you would like us to do, let us know how we can accommodate you. And then on the right, for people who are autistic, we created a different version of the pamphlet, and we're using those in the hospital now because we've implemented CARD. We've begun to implement CARD at the hospital for sick children. So we continue to build and expand on resources to help us in different parts of the hospital, not just with different types of patients, but also with different places where different types of procedures are happening. And if you maybe advance the slide, there might be some quotes here too, I think, from what people, first I have this. Yes, I have just a snapshot of one of the kids completed card checklists from one of the pharmacy projects that we did, where the child, you can see what they ticked off. They said they wanted to be with their mom. They wanted to take slow, deep breaths. They wanted to be told when it was happening. They wanted to close their eyes, and they wanted the provider, the immunizer, to talk to them about something they liked, which was Taylor Swift. So that's kind of fun. So that makes it fun for the child. And there's some quotes across the slide here that you can see about kids saying that they explained everything to me. It made me feel more calm, and it helped that they knew what I wanted. We have somebody else saying they cared about me, and then a parent saying my child's had many needles, and this is the most emotional support I've ever felt. Next slide, please. And the end, the final E, is about evaluation. So again, something that's in all the places where we go was never done systematically and never done with the amount of rigor that is needed to actually track these sort of things and make sure that we are providing the best care possible. But there was always time to do it. So there was always a minute or two after vaccination where people needed to wait. There was paperwork that needed to be filled out or something else where they could do the surveys, and they did. So we have over 95% response rates for all our surveys across our studies. And we use this to, again, debrief with staff, talk about their experiences, and try to improve processes, refine, and just get better and better. And over time, the staff just totally love this. It's so easy, and it really makes them feel good to know that patients are saying great things about their service. Next slide, please. So I mentioned as well that CARD helped us to deliver vaccinations in a more patient-centered way or person-centered way. And this slide summarizes some of the considerations for what makes care person-centered. And just to say that with CARD, we teach people about the types of decisions they can make, all the options that are available to them. So unlike a usual paternalistic approach, which says, here, I'm going to offer you distraction, or how about you do some deep breathing now, where we're imposing coping choices on others. This is different. It allows everyone to know, have the full menu of what they can do, and they can choose. Very empowering, and people are very satisfied to be included, not to be treated like, they don't matter, and supporting them in their choices. So this all sort of works with this model. And on the right, I've written down some points just about even, not even considering people who are autistic, but even more generally by gender or by age, how we treat people during vaccination and how we make assumptions about what they're allowed to do or what they can do, and how this creates negative experiences for them. And in the school context, I'll give you some examples. For us anyway, with our experiences with school vaccinations in Canada, a lot of female students would like to have privacy as an option for their vaccination, and they'd like to have a support person with them. And generally, neither was offered, and partly because it was felt that they were kind of babyish or should be able to do this without a support person, and that their requests are not justifiable or not important. So we kind of dismiss what people want. And so we have tried to really impress upon people that these are things that we can offer, we can provide. It's really quite simple, actually, and we shouldn't be judging people about what we think they can do or should do versus what they really want to do. And having the checklist, people have told us, patients, that it really helped them to be able to get out what they want without them having to advocate, because they feel like there's a big power differential with providers, and this normalized it for them so that they could make these requests, and that having this accommodated really made a big difference to their experience. Next slide, please. And related to patient-centered care or person-centered care, one of the points on the previous slide in the diagram had to do with building trusting relationships, and we also heard that in the first presentation as well. Just to remind us, how we build trusting relationships is not just by showing people that we're competent, but also that we care about them. So when we do things the way people would like us to, or we honor their requests, we show them that we care about them. They matter, and we help to build trusting relationships. And of course, that also helps build vaccine confidence. Next slide, please. So across studies, I said CARD improved outcomes, and the types of things we were looking for were attitudes and knowledge about pain and fear, safety of vaccination in terms of reducing pain, fear, and stress-related responses. We make administration of vaccines safer, improving experience of patients and as well of providers, because if patients are happier, providers are happier too. And then we improve equity because we do literally accommodate the needs of individuals. Next slide, please. This slide is for your information only, just to provide more of the data regarding what the trials are about, what they're like, where we get this evidence for what I just told you in the previous slide. If anyone's interested, I can provide those primary references. We've done studies more since this slide was created, not yet published. We're probably close to maybe, 16,000 people across different studies since 2019, the first study there. Next slide, please. This is the final slide before wrap up, where I just want to point out some of the more recent studies where we were able to get some information about CARD out ahead of time for patients to read about on websites, this sort of thing. And the second row of this table shows you what % of people said that actually having that information about CARD influenced them to come to the clinic. And it's maybe a little bit more than even we would have thought, but for some of the context, it kind of makes sense. So the first one, the hospital in 2021, that was the clinics we set up for people with high anxiety. And so that 90% of them would come kind of makes sense because they felt like they were going to be taken care of. But for the other ones, we're a little bit surprised. So vaccine pop-up clinics in university spaces. So these are, young adults. We have in 2022, when we first did them, a third of people who knew about CARD said it influenced them to come to the clinic, and then more so in the most recent set of pop-ups in 2023. And then in pharmacies, few pharmacies did put this information ahead of time, but again, more people than we would have thought actually said it positively contributed to them coming. So again, this speaks to vaccine convenience, right? So if we think of the 3C model that WHO had first created about vaccine hesitancy, we see increase in building of trust, and we see convenience, people speaking to convenience. I'm coming here because I think they're going to vaccinate in a way that's going to be acceptable for me. Next slide. Yep, so this is my final slide before concluding, and it's just to say, obviously, for people to do this stuff, it really is easy. It seems intuitive, but needs to be buy-in and needs to be processes put in place by the organization, by the managers. There needs to be training because some stuff is different, and we need to educate people, and we need to start tracking these kinds of side effects. So they are quality indicators of our vaccine delivery system, and we do want to be sure that we're accountable for providing the best quality of care that we can that has research evidence integrated into it. And at the end, now last slide, Anne, sorry. I hope I didn't take too much time. Just to conclude with the obvious, pain hurts vaccination. We have a protocol to help people turn this evidence about how to treat pain into actionable steps that really is customizable across populations and settings and helps us to build confidence in vaccination. And we have a website that is hosted by the Hospital for Sick Children where we post this stuff. So if anybody's interested, please have a look or contact me for any information that you like. Thank you.
Thank you very much, Dr. Taddeo. Our final presenters in this panel are Melanie Hoynoski, Eden Baker, and Allison Tappan from the Children's Hospital of Philadelphia. Your slides are up. Eden, I see you on the video. Please start. Please begin.
Thank you so much. We really appreciate this opportunity. My name is Eden Barker, and I am joined by my two colleagues, Melanie Hoynoski and Allie Tappan. We are Child Life Clinical Advisors at the Children's Hospital of Philadelphia. Here to talk with you today. Next slide, please. So for those of you who aren't aware, what is a child life specialist? A child life specialist is trained to study the way a child's brain develops and functions at each stage of development. We then apply this knowledge to address the psychosocial concerns that can accompany stressful or traumatic events. Our overarching goal is to promote optimal child development while reducing adverse effects. We do this through multiple methods, including play, preparation, coping education, procedural support, caregiver and sibling support, and also encouraging the use of pain management strategies, such as what the previous presenters really talked about already. A lot of distraction, implementing pain management devices, and comfort positioning. Historically, child life was born in the healthcare setting, which is why most often you find child life specialists in Children's Hospital. As the profession continues to grow, though, child life is actually expanding to any area where a child can encounter stress and trauma, such as in court systems, foster care agencies, sexual abuse clinics, and even schools. Some child life specialists are actually even opening their own private practices, which has been a great addition to the field. At CHOP, our department has over 100 child life specialists and includes creative arts therapies, a pet therapy program, a media program, and a hospital school program. Next slide, please. The three of us that are here on this call, we actually make up our small but mighty team that covers almost our entire ambulatory network. You can see this here on the map. Our ambulatory network includes 32 primary care sites, 15 specialty care sites, and 15 hospital partners. To cover this area, we have had to become pretty creative. Next slide, please. As you can imagine, we function very differently from our colleagues based at the two main campuses. We rely pretty heavily on partnering with our multidisciplinary team throughout each facet of our work, which is divided into 3 buckets: project work, staff training and education, and then lastly, patient care. Now that you have a little background on our role, we hope to talk with you today a little bit about the unique way our team supports all patients in the ambulatory network through the use of innovative approaches that empower staff and families with the knowledge and tools needed to create a less stressful vaccine experience. I'm now going to pass off to my colleague, Allie Tappan, who will dive a little deeper into this. Next slide, please.
Thank you, Eden. As Eden mentioned, being a team of 3, we have to think creatively about how we support our large ambulatory network. Given the changing landscape in primary care, we also have had to remain flexible and informed. Many of us are seeing higher acuity levels, both medically and psychosocially, which has prompted a call to action throughout pediatric healthcare. Our program has responded by taking a holistic approach by doing the following. We are offering telehealth to patients and their families, which has increased access to our services and decreased travel inconveniences for them. We have assisted in authoring clinical pathways focused on standardizing care when supporting children with challenging behaviors, as well as pathways that address de-escalation interventions that best support staff in a clinical setting. We also adapted the content of our staff trainings and tailored them to include scenarios with neurodiverse and behavioral health patients. This was important since 59% of our referrals are patients with either an autism or behavioral health diagnoses. We have remained diligent in developing educational resources obtainable to the community, and we are actively engaged in a vaccine pain management quality improvement project, which my colleague Melanie will share more about shortly. All of the facets of our work are focused on improving the patient and family experience. Next slide. One of the educational learning opportunities or resources we created is featured here. It is an interactive vaccine resource and is intended to help visually prepare children for their vaccine experience. It has multiple components to address the needs for many children, including those on the autism spectrum. For this reason, it was reviewed by many, including CHOP Center for Autism Research and our Office of Diversity and Inclusion. We really wanted our patients and families to feel seen as they walked through this experience. Next slide. The options for learning allow the child to choose either a printable visual schedule, an interactive slideshow, or an animated video. The printable visual schedule can be adjusted depending on the clinic's workflow and the child's preferences. The slideshow allows the child to move through the steps of the vaccination process, and the video includes information on why vaccines are created. Vaccine administration is just the first resource we created, and we look forward to expanding this to other healthcare procedures that can be challenging for patients, such as blood work or even well checks. I'm now going to pass it off to my colleague, Melanie, who will share more about another project we are excited to be a part of.
Thanks, Allie. As Allie mentioned, we are a part of a multidisciplinary team who is leading a vaccine pain management initiative in primary care. I know we don't have to necessarily convince this audience of the need for such a project, but we did want to make mention of this work. To get a better understanding of how frequently VPM, as we have coined it, is used in our network and what factors influence utilization, staff completed an online survey. We also used an evidence-based process to review the current literature, CHOP primary care vaccine statistics, and Press Ganey survey feedback, all which further validated a gap in care. Fast forward a year, and now a multifaceted approach is currently underway and supported by our Center for Healthcare Quality and Analytics team, along with ambulatory leadership and stakeholders. We are currently planning to pilot a bundle of strategies at 2 primary care sites with a goal to increase VPM utilization by 25%. We do expect this work to host a multitude of benefits, some of which include reduced safety incidents and increased patient and family satisfaction. We are also anticipating this work to have a positive ripple effect on the vaccine experience for autistic children and their families, along with more timely vaccination for all patients. Next slide, please. CHOP has over 100 community programs ranging from small grassroots efforts to large initiatives. We've been getting more involved in these community projects, some of which are listed here. One of them we can highlight is a partnership with the Philadelphia Department of Public Health and Center for Autism Research. We are working together on a grant-funded project to improve the primary care experience for pediatric patients with autism who are seen within our non-CHOP city health clinics. We're in the process of developing a training to increase participants' understanding of autism and to equip learners with universal strategies to support their autistic patients and families during primary care visits. Once data is collected, we hope to expand this project to other Philadelphia healthcare programs to increase our city's awareness and approaches to care when working with autistic children. In addition to this project, you can see that we're also involved with the Vaccine Education Center a medical assistant fellowship program for Philadelphia high school students, and several projects related to COVID testing and vaccination. Next slide, please. And that wraps up our time together, but we welcome any questions or conversation during the Q&A or through email, which is listed here. Thank you so much.
I want to thank all of the members of our of this most recent panel. All very interesting presentations. Mitch Rotholz, looked like you might want to make a comment from the chat.
Oh, thank you, Dr. Hopkins. Great presentation. Thank you all for giving those perspectives, and the tools that you shared, I think, are awesome. I just wanted to give a clarification on the pharmacy slide that was put there. That program is not the only place where pharmacists and student pharmacists get training in working with different types of patient populations. Just like any healthcare providers, there's needs across the whole healthcare system for giving providers the knowledge and comfort level of working with individuals with needs. And so that's what also led to work that's being done by the Autism Society of America, actually creating, similar to what was done in Canada. I love those cards that you provided, but giving providers the tools and understanding of how to make the healthcare experience a positive one for the patient and for their family and caregivers. So any tool that we can do, I totally agree, collaboration, but we need to just be working across the spectrum, working together to meet the needs of these patients. And so anything we can all do collaboratively to equip our healthcare providers, and I'm not even talking just on pharmacy, I'm talking about other healthcare providers who are providing services to individuals with needs. I have a son with disabilities, and I can tell you I've seen the good, the bad, and the ugly in all of our interactions across the healthcare system. So thank you all for the work that you're doing and for having this discussion.
Thank you so much for that. I'll just jump in here really quick and just say, yes, you're absolutely right. That was just for the micro-credential that was, but I could not agree more with all points, and I appreciate you bringing that up.
Any other questions or comments before we move? All right, well, thank all the members of this panel. All three of these presentations were spectacular. Lots of good information for us to use, and will help us with better quality of vaccination care across multiple different settings. We've now reached our time for our federal agency and liaison member updates, and we're going to start with the CMS update from Mary Beth Hance.
Mary Beth, you're muted.
Is that better?
I hear you, Mary Beth. Please go ahead.
Okay, perfect. Great, thank you. And first, I want to say thank you very much to Dr. Hopkins for his really kind and generous words about our colleague Jeff Kelman yesterday. I did have to miss a portion of yesterday's meeting, but was very happy to be able to hear those. So greatly appreciate that. And also just want to take a moment to just remember him, as he was so important to CMS's work in so many areas, but particularly in vaccine work. And his commitment to working across agencies and to ensuring access to vaccine data that could be used through multiple agencies was, has made strides and will be a lasting legacy. So, and he also served, as I'm sure many of you know, as kind of an unofficial mentor to many people, including myself. And there are many of us who will remember his kindness and his just tremendous knowledge in this area. So it is a tremendous loss. And thank you again for your kind words and thoughts. I did have one update that I just wanted to share from CMS, which is to just let everyone know, and you may already know this because it was in a broad email blast that went out earlier today, that we have released an updated Medicaid vaccine toolkit. This is something that we started during the COVID period, and we have updated it to reflect the transition of the commercialization of vaccines and the Inflation Reduction Act coverage policies. And so that is now available on Medicaid.gov, and I can get the link to folks. But that was released, I think, last week through a listserv from CMS, and then it was amplified again from CMS this morning. So thank you very much, and really appreciate it.
Thank you, Mary Beth. Our next update is from ASPR BARDA, Kim Armstrong.
Good afternoon, everyone, and thanks so much for giving us the opportunity to give you our updates. So some highlights from our written updates are that BARDA is, the premier advanced research and development organization within the U.S. government that supports the advanced development, manufacturing, FDA approval, and acquisition of medical countermeasures against chemical, biological, radiological, and nuclear threats, as well as pandemic influenza, COVID-19, and other emerging infectious diseases. The Mpox outbreak that started in May 2022 is still ongoing as of February 2024, but has waned in terms of case numbers per day in terms of domestic cases. However, caseloads in sub-Saharan Africa remain an issue, and the Democratic Republic of Congo is experiencing a significant increase in cases of Clade 1 Mpox. As a part of our smallpox preparedness, BARDA is increasing its supply of the U.S. stored inventory of JYNNEOS, the smallpox and Mpox vaccine. The vaccine continues to be made available to jurisdictions for the ongoing Mpox response. BARDA continues its partnerships to develop better and more rapidly produced pandemic influenza vaccines that shorten pandemic influenza response timelines and increase vaccine accessibility to ensure the nation is prepared to respond to the next influenza pandemic. Protocol development for a BARDA-sponsored, randomized, double-blind Phase 2 clinical trial to assess the safety and immunogenicity of egg-based H5N8 influenza vaccine at different antigen dose levels and adjuvanted with AS03 and MF59 continues. Study start is projected for summer of 2024. And finally, under Project NextGen, BARDA, in partnership with Luminary Labs, will launch 2 prize competitions that will provide prize-based awards to partners that will, 1, focus on the formulation of RNA-based vaccines on microneedle patches, and 2, accelerate the development of single-dose vaccines that can support a rapid pandemic response. Thank you for your time this afternoon, and that concludes my update.
Thank you very much, Kimberly. Our next presentation is from DOD, John Iskander.
Thank you very much, Dr. Hopkins. DOD has effectively concluded its 2023-2024 influenza vaccine program. All 5 active duty service components, that's Army, Navy, Air Force, Marines, and Coast Guard, achieve vaccine compliance rates above the 90% target. For all military personnel combined, including reserve and guard components, compliance was 88%, a level which has been stable over the last 3 seasons. Similar to patterns seen in broader civilian populations this season, flu vaccine uptake among military beneficiaries was relatively low, with some variability depending on their exact TRICARE insurance status. DoD is now preparing for a Southern Hemisphere flu vaccine campaign, which will involve greater than 30,000 doses. An update related to some of the presentations yesterday. The Immunization or IZ Gateway project is a collaboration among DoD, CDC, and the VA to enhance completeness of vaccine records of service members and their dependents. Its goal is to connect the now universal DoD electronic medical record with individual state immunization information systems. Washington State was the pilot site with a go live last May. California, North Carolina, Florida, and Oklahoma went live at the end of August of last year. All immunizations documented in the DoD EMR will be sent prospectively to the respective state IIS. Healthcare providers can query their respective state registry for all beneficiaries, including service members. Last month, we confirmed that Texas, Virginia, Maryland, and Washington, D.C. will be added to the IZ Gateway project, which will bring the total of covered beneficiaries up to 4.4 million. That is my update for today. Thank you.
Thank you very much, John. Our next presentation is from HRSA, Roxana Deba. Roxana, I think you are muted.
Can you hear me? I am so sorry. I'm having trouble opening my Zoom.
No problem. You are loud and clear.
Thank you. And I don't know if my video is coming up, but you know, this is Murphy's Law. Oh, start my video. Thank you. I've been waiting all day. Anyways, the HRSA updates include the DICP, which is made up of the Vaccine Injury Compensation Program. And the highlight of that program is that we've done significant improvement in working our backlog, and the details are there in reference to, you know, how many millions of dollars have been awarded to attorneys as well as petitioners. And on the CICP front, which is a very different program than the VICP, they've thankfully received a lot of funds to really ramp up this program, because there's over 12,000 requests for COVID-19 related countermeasures, and thankfully they've gone through about 3,000. And those are the two updates from that branch. And then the BIPIC update is quite voluminous, because BIPIC does great things, and I will just leave the audience to refer to the attachment.
Thank you very much.
Thank
Roxana.
you.
Our next update is from Indian Health Service, Uzo Chukuma.
Hi, mic check. Can you hear me?
I hear you loud and clear.
All right. Good afternoon, everyone. And my apologies, I'm having some bandwidth issues, so I'm going to keep my video off to make sure I have connectivity. Thank you for the opportunity to present the updates from the Indian Health Service. My name is Uzo Chukuma, the Infectious Disease Branch Chief within the Office of Public Health Support, and also the IHS Indian Health Service Immunization Program Manager. We submitted a written response, but I would like to also share some highlights with you. The Indian Health Service prioritizes vaccination as a clinical and public health priority, and continues to promote efforts to improve vaccination in American Indian and Alaskan Native population. Our national effort includes the Indian Health Service E3 vaccine strategy, which is an effort to ensure that every patient at every encounter is offered every recommended vaccine when appropriate, including all ACIP recommended vaccines in all age groups. In partnership with staff at our federal, tribal, and urban Indian health organization facilities, we've collected and shared best practices and lessons learned from dozens of E3 champion pilot sites across the country to cross-pollinate our Indian Health Service system of care. Some of the best practices from our E3 champion sites around information technology, community engagement, clinical nursing, and pharmacy practices include identification of vaccine ambassadors to implement vaccine clinics in the community, including remote locations and villages, establishing baseline immunization training modules for clinical staff on addressing vaccine hesitancy, integration of vaccine into urgent care clinics, optimizing transportation and storage of vaccines at remote sites and villages, coordinating with facilities, women, infant, and children programs to offer recommended vaccine at each appointment. Timely implementation of the clinical decision support algorithm called the Immunization Calculation Engine, ICE Forecaster. expand access and use of the state immunization information system for patient screening, leverage drive-through mass vaccination clinics and weekend and health fairs for vaccination opportunities. During the 2022 fall respiratory virus season, the Indian Health was actively involved in a vaccine campaign to reduce morbidity and mortality caused by vaccine-preventable diseases in our vulnerable population. Once the monovalent recommendation was in place, the Indian Health distributed guidelines to clinicians, public health staff, tribal leaders, tribal communities to emphasize the importance of these countermeasures. The Indian Health Service also organized multiple informational webinars to educate providers on the vaccine recommendations. Additionally, the Indian Health Service Office of Information Technology, in advance to the vaccines being available, rapidly deployed informatics infrastructure such as the CVX codes and ICE forecaster updates for expedited implementation of the ACIP recommendation in Indian country. Collaborating with other federal agencies, the IHS worked to ensure access and distribution of COVID-19 and worked closely with the CDC to roll out the COVID-19 breach program as well. Following the ACIP recommendation, the Indian Health Service took action to include the long-lasting monoclonal antibody nirsevimab in the Indian Health Service National core formulary to ensure access for AIAN infants and young children. We also provided guidance to federal, tribal, and urban facilities to ensure that the recommendations that all infants below 8 months of age in their first RSV season and all AIAN children aged 8 to 19 months in their second season receive nirsevimab. Following the shortage during the fall, IHS also worked diligently to secure supplemental supply of the long-lasting monoclonal antibody for our population. We look forward to continued collaboration with our tribal and urban and federal partners to ensure access to safe and effective vaccines across the age spectrum for American Indian and Alaska Native people served by the IHS. Thank you.
Thank you very much, Uzo. Our next update is from NIH, Andrew Ford.
Hello, thank you for allowing us to provide some updates. At this time, I'd like to highlight a few items included in NIH's written submission. First, investigators supported by the National Institute of Allergy and Infectious Diseases showed that a messenger RNA vaccine designed to prevent human cytomegalovirus elicited long-lasting CMV-specific responses, outperforming a previous vaccine concept. The authors concluded that the mRNA vaccine concept showed promise for better performance than its predecessor in ongoing clinical studies, of which results are expected soon. These findings were published in the Journal of Infectious Diseases. Changing topics with respect to maternal COVID-19 vaccination, according to an NIH study, preterm infants born to people who have been vaccinated for COVID-19 had roughly the same levels of antibodies to the spike protein of SARS-CoV-2 as term infants born to vaccinated people. Moreover, in all infants, antibodies to the spike protein were higher among those born to individuals who had received 3 or more vaccine doses before delivery compared to those who had only 2 prior vaccine doses. And these findings were published in JAMA Network Open. And then lastly, in October 2023, the WHO Strategic Advisory Group of Experts on Immunization recommended the use of a tetravalent live attenuated dengue vaccine in areas with high dengue disease burden and high transmission in children ages 6 to 16 years of age. The National Institute of Allergy and Infectious Diseases provided extensive support to advance the preclinical and clinical development of the vaccine, including IND-enabling toxicology studies and first-in-human clinical testing. Thank you for your time.
Thank you very much, Andrew. Just to let you know, AHRQ, CDC, FDA, and VA have provided written updates. Will not be providing oral updates. Sorry for my tongue tangle. Next, Roxana Deba for ACCB.
Roxana.
Yes,
Oh,
yes,
there
I
you go.
think
I think this should be better, right?
Yes.
Thank
you're right.
you. So ACCV met in September of September 2023. Their actual next meeting is coming up right around March. And if anyone wants to look at the ACCV website, it was actually a very interesting meeting. And one of the questions they had, which is relevant to the vaccine compensation program, is there a relationship between the flu vaccination and brachial neuritis, which there is not at this time. And it's very interesting. So if anyone wants to look at those slides, and there's also 3 vacancies at the ACCV. So if anyone is interested, please look at the website and let us know, and I'll pass it along. Thank you.
Thank you very much, Roxana. Our next presentation is from AIM, Claire Hannon.
I'm sorry about that. Can you hear me?
I hear you, Claire, loud and clear.
Okay.
There you are.
Let me find my update.
Your video is up also.
Okay, great. Thanks so much. This has been a really great 2 days of information and presentations. So I've sent in a written update. So I just want to highlight a few things from that. We held our annual Leadership in Action conference, December 5th to 7th in Houston, Texas. This is a time when we provide leadership training and programmatic breakout discussions and sessions for public health department staff, immunization program staff, and other non-partner organizations. We're now looking forward to planning our 2024 conference, which will be in December in New Orleans. State legislative session preparation. We had such a great session yesterday on state legislation, and I wanted to mention that we are working very closely with immunization program managers to support their response to state legislative initiatives in their states. We recently had a webinar February 1st in collaboration with the National Public Health Information Coalition, highlighting best practices and resources for working with public health information officers and state legislative liaisons to address vaccine-specific legislation. The webinar offered insights on state legislative trends, what to expect in 2024, how to engage state legislative liaisons, and successful ways of communicating with legislators. The webinar is recorded and available to our members on our website. In partnership with the COVID-19 Vaccine Equity and Education Project, or CVEP, AIM conducted a media blitz promoting awareness of the Vaccines for Children program and the importance of vaccinating children against COVID-19. This was in 24 media markets, and also a PSA that we recorded went to many additional markets. So our Chief Medical Officer, Dr. Shelley Fiskus, did the interviews and recorded the PSA spots. So far, the media blitz has generated more than 750,000 media impressions. And we're just really excited to celebrate the 30-year anniversary of the Vaccines for Children program and to continue to encourage participation in it. And then finally, adult immunization. We will be convening a series of 8 regional meetings focused on improving adult immunization activities and adult coverage rates. These are, we're calling them Vaccine Access Cooperative, or VAC meetings, and we will bring together leaders from state health departments, immunization programs, Medicaid programs, provider groups, pharmacy associations, and other key immunization partners to develop strategies to support successful vaccination of adults. We're also assisting CDC with a pilot program in 10 awardee jurisdictions of the Adult Immunization Program Framework. And this pilot will assess feasibility, cost, and effectiveness of jurisdictional activities intended to increase adult vaccinations and to increase coverage rates. So thanks very much for the continued opportunity to participate in NVAC, and you can consult our written report for additional information. Thank you.
Thank you very much, Claire. Our next presentation is from ERA, Courtney Londo.
Hello. Hi, this is Courtney Londo, representative for the American Immunization Registry Association, or ERA. I'm pleased to be with you today to provide an update. We also have submitted a written report if you'd like more information. We're busy gearing up for the ERA 2024 national meeting, which will take place May 7 through 9 in Orlando, Florida. And this meeting provides an annual opportunity to bring our peers and partners together to educate on the latest IAS best practices and bring IAS discussion to a national stage. So we hope that we'll see you there. With a rollout of both RSV vaccines and a monoclonal antibody product for infants, IAS have been busy updating algorithms to ensure accurate data capture and forecasting for individuals. However, there are still some outstanding issues with solutions currently in the works. For example, children 8 through 19 months are at increased risk of severe RSV disease, receive 2 identical doses of 100 micrograms on the same day. IAS may flag this as a duplicate entry and delete 1 dose, which can make patient records, vaccines for children accountability, inventory, and reporting inaccurate. When a pregnant person is vaccinated for RSV, the IAS may capture the information for the pregnant person. However, there's not a linkage with the newborn infant record. Currently, IAS are not expected to link the birth mom with the infant record. For the first time since the launch of our Measurement and Improvement Initiative in 2015, ERA, McCaw, and CDC are thrilled to announce that 100% of the IAS jurisdictions have been measured in at least one content area. The M&I initiative is a voluntary program that provides IAS with access to valuable data and actionable insights to facilitate their alignment with the national standards. So we're really excited to have 100% participation. In July, ERA and CDC launched a new measurable concept, HL7 patient matching, in the testing and discovery phase of M&I. Patient matching is the process of identifying and leaking a patient's data across different health systems to create a comprehensive view of that person's healthcare record. And finally, if you'd like to learn more about ERA, please check out our 2023 annual report. This report offers a comprehensive overview highlighting our accomplishments and many activities throughout this year. A link to the report can be found on our website, mregistries.org, or in the report that we prepared for NVAC. So thanks again for allowing us this opportunity to talk through some of the highlights today.
Thank you very much, Courtney. Our next presentation is from American Pharmacists Association, Mitch Ruffles.
Thank you, Dr. Hopkins. I've submitted a written report, so I'll just give quick highlights. I know we're getting close to the end of the day. APHA's annual meeting is coming up in March in Orlando. Lots of programs around various immunization and public health topics. We're also going to be doing the Immunization Champion Awards will be presented at the meeting. As we talked about earlier in the previous topic discussion, APHA is collaborating and partnering with the Autism Society of America and also engaging student pharmacists in that initiative to train them on the importance of vaccinations. How do you approach the delivery of vaccinations for this patient population? And so there'll be a program at the annual meeting as well. We are various different training programs and giving updates after each ACIP meeting. And then last thing I just want to make folks aware of, and we talked about earlier in the meeting about RSV vaccination. We're collaborating with the American College of Obstetrics and Gynecologists. So we're doing a lot of collaborating with different organizations, including AIM and other organizations in the immunization neighborhood. Thank you for allowing me to give this update and for the engagement with NVAC.
Thank you, Mitch. Next is Erica McGowan from ASTO.
Hi there, can you guys hear me?
Hi, loud and clear, and I see your face.
Okay, good evening, everyone. Hi, my name is Erica McGowan. I am the Senior Director for Emerging Infectious Disease at ASTO. And thank you for allowing me to bring a few updates from our immunization program. ASTO has been conducting a policy academy for state and territorial health leaders to improve their capacity to identify, develop, and implement policies to address vaccine hesitancy. The first Vaccine Policy Academy focused on legislative trends and allowed participants to discuss strategies for increasing vaccine confidence among legislators, engage with community groups to support vaccine policies, and develop effective messages to advance vaccine legislation. The second session focused on vaccine-like products, specifically RSV and Nirsevimab, including policy implementation and lessons learned. Next, ASTO will disseminate the findings from both of those Policy Academy sessions in a publication soon. Additionally, ASTO continues to support our vaccine resource development. We're supporting our members by providing situational awareness and technical assistance on any vaccine-related activities. Therefore, we have developed a number of short podcasts on COVID vaccine uptake strategies, and also the RSV vaccine. ASTO has also developed blogs on containing and preventing the spread of infectious disease, public health in the courts, and also policymakers boosting public health readiness for a respiratory illness season. We also have released a revised immunization policy statement that was approved by our membership. The last update that I'll give you is about the COVID-19 IDEAS program. IDEAS stands for Immunization Data Exchange, Advancement, and Sharing. ASTO, with the support of the Office of the National Coordinator for Health Information Technology, supported a learning community to advance data sharing between state immunization information systems and also HIEs. As part of this project, ASTO released 2 reports characterizing the dynamics influencing IAS, HIE participation and partnership, as well as data exchange. And also the legal landscape of public health data sharing, which includes information on immunization data sharing. The learning community has recently ended. However, ASTO continues to develop sustainability planning materials and evaluate project initiatives. ASTO has submitted a report with our additional updates that will be attached. So thank you so much for allowing us to be here today and engaging with NVAC.
Thank you very much, Erica. Our next presenter is Matt Bobo from NACCHO.
Hello, can you hear me okay?
You're loud and clear, Matt, please.
Awesome, thank you. Thank you, Dr. Hopkins. So just a few updates from NACCHO. I'm just going to talk about 3 new funding opportunities that we just awarded to local health departments. They have similar themes, but different populations of focus. So for the first one, it's called the Strengthening Vaccine Confidence and Uptake Among Adolescents and Their Families through Community Partnerships. So NACCHO is funding 5 local health departments to work with local departments to increase youth advisory groups to identify and address current barriers to COVID-19 and routine vaccinations and uptake and confidence. You can see those 5 local health departments listed in our report as well as a press release. Another similar project that we're doing, but a different population, is improving vaccine access, education, and outreach through faith-based partnerships. So NACCHO is funding 6 local health departments to work with faith-based partners to identify and implement strategies to improve COVID-19 and routine vaccine. And you can see those 6 funded local health departments. And finally, through another initiative, we're improving the health of young children, expanding vaccination coverage through partnerships with early care and education programs. NACCHO is funding 14 local health departments to work with early care and education programs to identify and implement strategies to improve COVID-19 and routine vaccine. All of these individuals will be making communication plans and getting local communication out the door about improving COVID-19 and other routine vaccine coverage and confidence. Thank you so much for that opportunity. I appreciate it.
Thank you very much, Matt. Our next presentation is from Kelsey Young from the Public Health Agency of Canada.
Thank you so much. Sorry, can you hear me?
You are a little bit muted, but I hear you.
Okay, great. I'll just talk loudly. Hi, I'm Kelsey Young. I'm here on behalf of Erin Hendry, the Standing Liaison Representative for the Public Health Agency of Canada. Thank you for the opportunity to give a few updates. I would like to just highlight a few activities that are currently ongoing at the agency, but there's further information available in the written updates provided. So for a quick update on the measles situation in Canada, in 2023, a total of 12 measles cases were reported in Canada, with 11 of them being related to international travel. 5 cases were reported to this year to date, all of which have been travel related. And while the national vaccine coverage estimate for at least one dose of a vaccine against measles is 92% for 2-year-olds in Canada, our country remains at risk of importation of cases, especially in the context of what we heard yesterday about rising cases globally. Next, I'd like to just inform you about the work that's ongoing to renew Canada's national immunization strategy, which provides a framework for cross-jurisdictional collaboration, and this improves to improve the relevance, effectiveness, and efficiency of immunization programming in Canada. The renewal of the strategy, which was put on hold as a result of the COVID-19 pandemic, is focused on enabling consistent approaches to planning, purchasing, and delivering vaccines across Canada, and educating the Canadian public about immunization. In addition to revisiting the 10 priority areas that have been foundational to the strategy since it was first introduced in 2013, efforts will also be made to align the Canadian priorities with the World Health Organization's Immunization Agenda 2030. And publication of Canada's National Immunization Strategy for the next 5 years from 2025 to 2030 is currently planned for March 2025. And then lastly, Canada's National Advisory Committee on Immunization, NACI, which is our country's equivalent to ACIP, recently released guidance on an additional dose of COVID-19 vaccines in the spring, for the spring of 2024 for certain individuals at high risk of severe illness due to COVID-19. NACI has several other upcoming publications planned, including a pneumococcal statement on the use of PCV 15 and 20 in pediatrics, as well as an annual influenza statement, which includes updated guidance on influenza vaccination for adults 65 years of age and older, as well as further advice for COVID-19 programs. As part of our country's continued ongoing efforts to resume non-COVID-19 related initiatives, there is ongoing work to provide immunization advice on Mpox, RSV for pediatrics and for seniors, HPV 1-dose series, as well as further advice for pneumococcal vaccines, and rabies PrEP and PEP. And NACI's 2024-2026 work plan is currently under development, and we are expected this to be finalized this spring. And Erin will be able to provide updates on that at any future meetings. And that was it for me. Thank you.
Thank you very much, Kelsey. We have written reports from AHIP and VRPAC, but neither will be giving a verbal update today. I understand from Anne that we do not have any verbal public comments for our second day. So this is the conclusion of our February NVAC meeting. I want to thank all of our members, all of our support staff, and all others that have participated or listened into our meeting. I hope that you all have a safe and happy weekend. Continue to vaccinate, reduce vaccine preventable disease, stay safe, and look forward to hopefully seeing all of you all in June at our next meeting. Be well and be safe.
Produced by the U.S. Department of Health and Human Services.